Glaucoma and eye pressure. Understanding the causes and treatment of glaucoma using an interactive model. Eye pressure or intraocular pressure is the primary indicator and only leading indicator of glaucoma. Furthermore, intraocular pressure is the only modifiable factor in glaucoma treatment. Therefore, an understanding of intraocular pressure is really critical to understanding the causes and treatments for glaucoma. I'm going to segue over to the model. This is an interactive model shown on the screen and is able to guide personalized glaucoma interventions. It is based upon novel equations built upon Hans Goldmann's original work in the 1950s, but it incorporates many new concepts over the last 65 years. The development of the equations will be described and published separately along with the interactive model. Intraocular pressure is described by the inflow of fluid into the eye balanced by the outflow of fluid out of the eye, denoted by these two lines. The equilibrium in which the intraocular pressure occurs is where these two lines intersect. Also, intraocular pressure is able to change over time. So this model is able to do that. If we were to, say, deflate this eye to a pressure of 0, we could determine what amount of time it would take to get it up to its nominal pressure of 16 millimeters of mercury and an average flow of aqueous fluid through the eye of 1.33 microliters per minute. We'll place this back up to a nominal 16 millimeters of mercury so that there is no change in it. Conversely, we can also start at a high pressure and see how long it takes for it to be able to get down to a nominal pressure, its steady state pressure of 16 millimeters of mercury. And this is just an average eye that we're looking at right here. Now, in addition to that, there are many modifiable variables shown over here in the upper left, which affect intraocular pressure as well as its time variations. In addition to that, we also have a third graph over here that shows the diurnal variation of intraocular pressure. So as the percentage change of inflow versus outflow through the evening, we can show that there is a definitive increase in the spiking of intraocular pressure that occurs at night. We'll put that back down to its nominal values and leave it right there for right now. Now, let's examine these factors over here which affect intraocular pressure. We're set now for just a normal eye of 16 millimeters of mercury with a fluid flow of 1.33 microliters per minute. And we can change various things. We'll start with just the episcleral venous pressure. So this is the venous pressure. It allows outflow of fluid out from the eye. And say we were to have some disease process like a arteriovenous fistula. Now we'll increase that pressure significantly, and you'll see now we become ocular hypertensive. We've developed that greatly increased pressure. It occurs over a period of time, and not only that, it exacerbates the diurnal variations that we see at night. Conversely, we can reduce the venous pressure as a whole, which decreases the episcleral venous pressure very slightly, and we can reduce the intraocular pressure slightly with that. We can also have interventions such as negative pressure goggles, which also can reduce this episcleral venous pressure, which also can have a direct effect on the intraocular pressure, bringing it back from 16 down to 13.5 millimeters of mercury. Let's put this back at our nominal value of 8 as we proceed forward. In addition to that, arteriolar pressure can also affect the intraocular pressure. So if we look at our arteriolar pressure, and this is not the mean arterial pressure, this is actually the arteriolar pressure intercept, but say we were to take this, and they're relatively linear, and we reduce the mean arterial pressure in a patient, say they were running at 200, and they were running at 150, and we brought them back 20 millimeters of mercury, so we can reduce this by 20 millimeters of mercury down to, say, 128 or something approximate of that there is a reduction from about 16 millimeters of mercury down to about 15 millimeters of mercury. It's not a lot, but it is some, and it is able to show this difference due to mean arterial pressure changes. And we'll put it back up to where it was roughly previously. Now, common primary open-angle glaucoma is typically caused by a decrease in outflow facility, which we're able to model with this as well. So in glaucoma state, you actually reduce the outflow facility. So we can bring this down to something that then puts us in an ocular hypertensive state, brings it up from 16 millimeters of mercury to 23 millimeters. And you see the shift in the outflow facility curve where you get a shift in equilibrium. Also, there's a time variant where it increases that pressure over a period of time, which is rather extensive. And again, there's this increase in amplitude and diurnal variation as the pressure increases. Leaving it at this hypertensive state, we can also include other interventions. Let's say we add a drop to this patient, latanoprost. Now, latanoprost can be assigned a outflow facility that's independent of anything else that's going on. And let's say we set it at 0.06 microliters per minute per millimeter of mercury. So we'll go down here to what we call interventional outflow facility, and we'll increase that by a 0.06. Let's bring that up to there, and now we have several different lines on here. One is the original prior to intervention, and the second is intervention. And we see that there is this reduction in intraocular pressure. Now we have several intercept lines here. This is the endogenous outflow facility. This is the interventional outflow facility, and this is the resultant of the two. And this gives us our new intraocular pressure that we're able to see right where these two graphs meet, and brings us down from 23 millimeters of mercury down to approximately 17 millimeters of mercury. Now, let's say in addition to that, we say, okay, well, we're going to do cataract surgery. How is that going to affect? On average, you can assign a outflow facility of cataract surgery to increase that interventional outflow facility by, say, 0.02. So we'll drag this up by 0.02 because they're directly additional. And again, we have some increase in the outflow facility, which then further reduces this intraocular pressure from 23 millimeters of mercury down to 16. And again, you can see the confluence of the two outflow facilities at this point. Now, let's say in addition to that, we also decided we were going to do an eye stent procedure during our cataract surgery. That also is additional, and say we can add another 0.04 to that. And so we'll add an additional 0.04 to that, bringing us to 0.12. And how much further does that reduce the pressure? It gets us down to about 14.5 millimeters of mercury from 23. Again, a significant reduction in intraocular pressure via these standard treatments that are pretty typical these days. Now, we can also add, let's put these back, so we're back in the ocular hypertensive state as well. We'll just leave it right there. And let's say at this point in time we decide, okay, well, we want to reduce, well, let's go back actually. Let's take this back down to 0. We're in our ocular hypertensive state, and let's say we just want to add a aqueous suppressant such as acetazolamide. Now this can also be assigned an average independent inflow facility, and let's say they're not directly proportional to each other, but let's say it's a negative 0.005. So we'll take this inflow facility and we'll reduce it by a negative 0.005, take it down to that. And we can see that it drops this, kind of put this up slightly, don't we? It drops the equilibrium pressure down to, from 23 millimeters of mercury down to 16 millimeters of mercury. It's a significant drop. We'll put that back up where it was previously. And inflow facility of 0.01, which is relatively nominal. We have our interventional, which was what, at 0.12, right there. Let's say we add the aqueous suppressant after we do this, all of these outflow facility interventions, and say we take it down to 0.05 right there. Now it just barely reduces the intraocular pressure. Well, actually, it does actually reduce the intraocular pressure. Hang on, let's put it back up where it was, roughly. We're at 15, and let's say we take it down to 0.05. Yeah, it does. It significantly reduces the intraocular pressure as well. Alternatively, we can have other processes, say neovascularization of the iris without angle closure. That would increase the amount of inflow facility. And let's say we have that by ultrafiltration, just pumping fluid on to the inside of the eye via any type of arteriolar pressure, and that would significantly increase the pressure inside the eye just due to neovascularization of the iris. And that also gives us an understanding of the actual disease process. I started at 16. Put that back where it was. And we'll take our interventional, just take it back down to nominal where we're no longer using the aqueous suppressant at point, roughly, there we go. Now, all of these things are effective in understanding this model, and we can explore any number of disease processes as well as interventions and their effect on intraocular pressure. Furthermore, all interventions can be assigned an average independent facility value to compare their effect on intraocular pressure either alone or in combination. This allows a patient-specific tailoring of interventional treatment for glaucoma. Thank you so much.